Thanks for coming to seminar today. I want to introduce our speaker as soon as Suri stopped talking.
We were quiet over here.
What's that?
We were quiet on this side.
Yeah, you guys were very well behaved. It's over here I'm worried about. So thanks for coming. Today we have a guest speaker, Dr. James Antoon. He's a physician in the assistant professor in the clinical pediatrics division of pediatrics and developmental pediatrics, and he's worked with Todd and I on some research ideas. He's interested in drug safety in children. He's also on Rachel's dissertation committee. And hopefully there's others in the future that he can help participate and do some research with us. Just his background, he has a MD and PhD so he's an MD and a PhD in pharmacology, both from Tulane University in Louisiana, and he did an internship and residency in North Carolina.
What part?
Of Louisiana?
North Carolina.
Chapel Hill.
Me too. I like you. Yeah.
So he's currently practicing pediatric hospitalist here at our hospital, at Children's Hospital of Illinois. Is that what it's called? I never heard of that. Yeah, cool. And his research focuses on pediatric pharmacology, improving evidence-based care in hospitalized patients, and drug safety in kids. He's received several national and regional honors, the Paul Claresby Medical Research Fellowship, Award of Excellence in Academic and Experiential Pharmacology, and the John Taylor Greater New Orleans Pediatric Society Award. He has a bunch of publications, and he's going to talk today about some work he's done using a couple different interesting databases that you might be interested in, and it's based on drug safety work. So, thanks.
Thanks for having me. So, severe cutaneous drug reactions just means Stevens-Johnson. I got interested in this a few years ago when I was in North Carolina in Chapel Hill, and I was at one of the large referral pediatric hospitals. And there was a 6-month period where I had 5 or 6 cases of Stevens-Johnson. And it sort of hit me that either I was seeing every single case we had in the state, because there's 2 million children in the state and the incidence is about 1 in 250,000, or this is a lot more common than what we thought. And then the other reason I got interested in it was hearing the large and intense fights that physicians got into about treatment. There are no standard of care treatments for this, and people are very intense in the way that they want to treat due to the lack of evidence. And so for those 2 reasons, I started to research this a little bit more. So I don't have any disclosures, and I will be discussing off-label treatments because there are no FDA-approved treatments for Stevens-Johnson. So everything that I mentioned for treatment is off-label. So I'll talk a little bit about the background of the disease and then some of the primary data that we did with our group concerning the epidemiology of Stevens-Johnson in kids, what people are doing as far as management, what their outcomes are, mortality, length of stay, and then some of the societal costs that we've been able to quantify. And then I'll go over some of the future directions that we're going to pursue. This girl in the corner, her name is Samantha Reckes. She was a 7-year-old and got Stevens-Johnson in 2011 and won a $63 million lawsuit in the state of Massachusetts. Due to her Stevens-Johnson, it became a national story. And that was right around the time when I started to get interested in this. And we'll come back to her. So background a little bit, this is the first study on Stevens-Johnson by Albert Stevens and Frank Johnson, who were both pediatricians. It was 1922, and they saw 2 cases of children who came in with a fever, oral lesions, and then a diffuse rash where they clinically worsened over about 8 days and then got better and went home. They did not correlate this with any drug use. They thought it was an infectious process at the time. So severe cutaneous drug reactions are broken down into 2 main groups, Stevens-Johnson and then toxic epidermal necrolysis. They're the same pathophysiology, so it's something on a drug or on a bacteria or some antigen looks like something on the epidermis, and it goes through an immunologic cascade starting at the FAS-L ligand or CD95 ligand, where you get an immune complex-mediated separation between the dermis and epidermis, and then it starts to necrose. That's about as much primary physiology as I'm going to go into. What's important to know is that this is not just a mouth and a skin disease. It's any mucosa in the body. So that's your eyes, that's vagina, urethra, your GI tract, your lungs. So while we typically think of this as a skin disease, it actually affects every organ in the body and can have very serious long-term consequences with it. So Stevens-Johnson and TEN are the same disease, just different spectrums. TEN was discovered about 20 years after Stevens-Johnson, and people really didn't put it together until the 60s that they were the same disease process. Stevens-Johnson, we say, is less than 10% of the body's surface area involvement as far as detachment of the skin. TEN is greater than 30% of body surface area, and then there's a separate diagnosis code for the SJS-TEN overlap syndrome, which is the in-between 10 to 30%. We like to think of it as a mild, moderate, severe disease when we describe these, except that the mild part, the Stevens-Johnson, still comes with a 10% mortality and long-term complications and is very serious. So it's really not that mild. It's just better than having TEN. But for the most part, when I say Stevens-Johnson, I mean all of these put together. I consider them one disease. So the epidemiology, incidence in adults, there's varying studies. Altogether, it's 0.4 to 6 per million. In general, it's about 1 in 200 to 250,000. Stevens-Johnson is more common than TEN, so the less severe form is much more common. There's a female predominance, and then there are known risk factors, which HIV being the most potent, but also one of the least common now. Malignancy and autoimmune diseases, especially lupus, are known to be high risk factors for Stevens-Johnson, which makes sense when you think of this being an immunologic disease, and then when you have an underlying problem with your immune system, you're going to be more likely to get it. And then there are some ethnic disparities as well. So causes, drugs by far the most common cause, and the one that most people attribute to Stevens-Johnson. Bacteria, especially Mycoplasma pneumoniae, but any mycobacterium can also cause Stevens-Johnson. There's been very specific outbreaks in localized areas of Stevens-Johnson from certain strains. Vaccines can cause Stevens-Johnson. If you name a vaccine, I can show you a case associated with it. Herbal remedies, which we don't see as much as we used to in the 90s. There were some high-profile cases with herbal remedies that had us stop using them quite as much. So not SEAL, but lupus is a risk factor in itself can cause Stevens-Johnson. So it's an immune complex-mediated disease that might have something on the surface that attacks that makes the immune system attack the epidermis. And then different chemicals that are used in laboratories can cause it as well. So there were two big adult studies that came out where we get most of our data for Stevens-Johnson. They were the SCARS, Severe Cutaneous Adverse Reaction, and then the EuroSCAR studies. They were retrospective. They had about 300 or 400 patients in them. They were very well designed and gave us a good analysis of what drugs can cause it and what are some of the outcomes with Stevens-Johnson. So with these studies, we found that almost all of them were due to drugs, somewhere in the 90% range. They could attribute this to some drug. There were lots of different drugs that can cause Stevens-Johnson. Most drugs, if you look hard enough, you can find a case with it. But what was surprising to physicians was the drugs that they found associated with Stevens-Johnson. So we were all taught way back when that it was your antiepileptics and it was your sulfonamides, especially Bactrim, that caused Stevens-Johnson. But the number one cause was allopurinol in these studies, which was very surprising to us. And then colchicine was also up there, which is something that we use pretty frequently that we don't really think about Stevens-Johnson with. But this girl, Samantha Reckless, got her Stevens-Johnson and her 150 surgeries from Motrin. So she took over-the-counter ibuprofen and got Stevens-Johnson. So what is important is how often the drug causes it, not necessarily if it causes it. So a little bit about the clinical course. I'll go through this pretty quickly. So it starts with a fever, a headache, a sore throat, and then you get a diffuse rash that's fairly progressive. And in the first couple days, it'll either progress and get worse or it'll start to get better. And then you can have later on in the acute phase, usually after a couple days, you get your acute complications. That's where you have your skin breakdown, you get your infections. The number one cause of death in these children is infection and septic shock. They get bacteremic, they have electrolyte abnormalities because their skin surface area starts to shrink because it sloughs off and they can't control their electrolytes. And then they get everywhere that you have mucosa in your lungs, in your GI tract, in your urethra, those can all infarct, and you can have sloughing of dead skin cells. And then there's a high mortality rate associated with these. And then they also have long-term sequelae, so they get scarring of joints, scarring of skin, scarring of your eyes, your liver, your kidneys. Most people have some sort of problem with their Stevens-Johnson later in life. Did not mean to click that. All right, so I'm going to show some photos. They're pretty disgusting, so if you don't want to see them, shut your eyes. I'll just put them up and then take them down. So this is what it looks like. This is moderate Stevens-Johnson. So it's pretty bad. It can be a lot worse than this. But you can have it where it's just your mouth, your lips, a little bit of a rash, and then it goes away, and those are the best case scenarios. The worst case scenarios is what you see, but worse in death. So the treatment, we know that if you stop the drug that they were taking that was causing their Stevens-Johnson, or if you treat whatever infection that they had that caused it, that increases mortality and that they get better. It's now standard of care to put these children and adults all in intensive care units or burn centers. Preferably burn centers because they're a little bit more adept at skin grafts. But most ICUs are associated with a burn center and will end up transferring them. And we know that the faster they get to an ICU, the better their outcomes. It is shocking to me the amount of studies that we have on the treatment of Stevens-Johnson. They're almost all retrospective or just very small 4 or 5 patient case series. There's really nothing other than showing that something is safe to use, but not very much in the way of efficacy. But what people tend to be doing, or what's out there in the literature, is you try and suppress the immune system somehow. And so this is where people get into these very loud arguments. Should you do steroids first? Should you do IVIG first? Should you do a TNF inhibitor, now that we know that it involves the apoptotic pathway with the FASL ligand? Should you plasmapherese them, which comes with its own complications, but will get out that immune complex that's causing the problems? And so this is where there's a ton of debate in kids and adults of what to do with treatment. So here's why I care. There's an old saying in pediatrics of pediatricians are not internal medicine physicians for kids. And pediatricians get really sensitive about this. And it took me a while to figure out why. But really what that means is adults are not just big kids. And the physiology is different, and it's very different, especially the immunology. So children have rapidly changing immunological processes from birth up until about puberty. And you can never tell what their immune system is going to do. It's why their infection rates are higher, but it's also why they survive diseases better. If you get acute lymphoblastic leukemia as a child, you're probably going to live. If you get it as an adult, you're probably going to die. And you can pick any disease, and there's going to be different outcomes between kids and adults. So this is Manute Bol, who was the 7-7 center for the Washington Bullets. He was born in the Sudan. He was kind of famous as a shot blocker in the 80s and 90s. He got Stevens-Johnson when he was 50 years old, and he died about 2 weeks after he got it from infection. Padma Lakshmi, I think that's how you say her name, got Stevens-Johnson when she was 14 years old and is a supermodel and doesn't seem to have any major problems from it. And so our question was, what's the difference? Why did Manute Bol die and Padma didn't? So when we look at the pediatric literature, there's really 2 main studies that are out there. They're both retrospective studies from 2 centers that involve, the first one, that recurrence paper, involved 55 patients, and the medications paper was 80 patients. So the first one looked at 2 Toronto children's hospitals retrospectively for 7 years, found 55 cases. But what was interesting about that study is they found that about 50% had a drug that they could identify associated with their Stevens-Johnson, and about a third were associated with an infection. And so that kind of implied that maybe kids' infections, for whatever reason with their immune system, leads to Stevens-Johnson more than adults. And in about 18% of cases, they weren't on any drugs, and they didn't have any infectious symptoms, but they still got Stevens-Johnson. So They speculated that maybe this was an underlying autoimmune disorder that hadn't presented itself, that can happen sometimes in kids, but they really don't know why a lot of these patients got their Stevens-Johnson. The other surprising thing about the study were the outcomes. So they found a 2% mortality rate compared to the 10 to 30% in adults. And this study wasn't powered for mortality, so you have to take that with a grain of salt. There were only 55 patients, but it did suggest that kids might do better with this. But they also found that about 50% of kids had long-term problems from their Stevens-Johnson, and that's a little bit less than adults, but still on par with what you would think. The other study looked at what drugs might actually cause Stevens-Johnson. So they had 80 cases and about 200 controls, and they identified the high-risk drugs. And what was surprising to me was some of these drugs are ones that we use every single day in the hospital, so like cephalosporins. When I mentioned earlier, when I saw a couple cases in a row of Stevens-Johnson, 2 of them were from ceftriaxone, which you usually wouldn't think. And when I went looking in the literature about could it have been it, this is the study that I found, that cephalosporins actually do come with the risk of Stevens-Johnson. So do steroids, which is surprising because that's what we use to treat Stevens-Johnson. And then benzodiazepines, a lot of kids have seizures or getting benzos, and then some of your H1 blockers for your allergies, your seasonal allergies can cause it too. So these were drugs that we typically didn't think of with Stevens-Johnson that turned out in kids are high risk, that are less of a risk in adults. So somebody followed 12 or 15 kids long term to see, what did they have any different complications than adults do, and they have about the same complications as adults. And this study showed at about the same rate. Most of them were eye complications with keratitis, uveitis, some eye scarring, but they also had cholangitis and scarring in the liver. They had kidney problems. They had a lot of skin issues and multiple surgeries with scarring of the skin. And then this other study came out over the summer, and it looked at adults, and they followed up adults at 1 year and 5 years after their Stevens-Johnson when they were discharged from the hospital, and they essentially gave them a survey that looked for PTSD, and they found that about 60% of them had clinical criteria for post-traumatic stress syndrome from their Stevens-Johnson. So this isn't just a physical long-term problems, it can be mental long-term problems too, because they spend a lot of time in the hospital, have a lot of surgery, they lose their jobs, they go broke from all of their hospital costs. So it's not nothing even if they do pretty well. So our question was, what about kids? How common is it in children? Is it the same as in adults? How are people actually treating this? I know what people do at the institutions where I've worked, but we really don't know what people are doing nationally, whether they're doing steroids, IVIG, both, something else. And then what are the outcomes? What's the mortality rate? What are the long-term complications? What are the short-term complications that kids get? And then how much is this going to cost us, and what is the most cost-efficient way of treating Stevens-Johnson? Because all the treatments that people are doing are pretty expensive treatments, and if one is better than the other, we should be doing that one and not both. So a little bit about methodology. Doing studies in pediatrics is very difficult. Stevens-Johnson is a low incidence disease, and it's very hard to do a prospective study on something where you're waiting an entire year to get a patient. But pick a disease, and the incidence is probably even lower in children. Kids tend to be pretty healthy, and so whatever problems they have doing prospective studies in adults, it's going to be even harder in a pediatric population. Getting a prospective drug study through an IRB is like a new layer of hell. I don't know if anybody's tried it. Here it's even worse than other places. And doing an investigational new drug. If a drug is approved in adults and you want to study it in kids, you still have to do an IND. It still takes months and months to go through. These are all just barriers to doing prospective drug trials in kids. Putting a new treatment out there, you're not going to get anything through an IRB if you're doing it against placebo and something that's has any mortality or morbidity to it. And then following outcomes in kids, to truly do it, you have to do a 60-year follow-up, which is impossible to do. So long-term outcomes can be difficult to determine in kids. So what we decided to do was a retrospective study. And we decided to use 2 different databases, which I'll go through. And we took kids 0 to 18 years old who were admitted to the hospital. Since all Stevens-Johnson, even the very mildest form, still gets admitted and monitored for progression, we felt that we were going to pick up all of the true cases of Stevens-Johnson because they should be admitted to the hospital. And we looked at discharge diagnoses of Stevens-Johnson, TEN, and the overlap syndrome. In 2008, we changed our diagnosis codes. There used to be one code for all three of these, plus one for erythema multiforme major, which is sort of some people put on the mild spectrum of these. In 2008, that changed, and so we got more specific codes. We also decided, since these codes are validated in adults but not kids, that we would try and do a little bit of validation in that if you had any disease that looks like Stevens-Johnson, so staph scalded skin, Kawasaki disease, morbilliform drug reactions, we were going to exclude you from the study to say, well, maybe they started with Stevens-Johnson, forgot to take the code off, and they really had Kawasaki disease. And then if there weren't any billing data available, we didn't include them because we wanted to do some cost analysis as well. So the first database that we looked at was the Kids Inpatient Database, which is the Medicaid, Medicare database. This is one that we have in the Department of Pediatrics. If anybody would like to use it, I'm happy to collaborate with you. We purchased it to do these kinds of studies. And what's nice about this database is it's weighted for national estimates. So Lurie Children's might be 1.8 in the database, and we might be 1.2, but you can at least get actual incidence and prevalence data if you want to, because it's a national representation of the population. It's a very large database, 4,100 hospitals. It has lots of admissions. It has about 15 million kids in it. It's a pretty big, nice database. The problem with this is that you can't track patients across encounters, so you can't look at readmissions with it. So the other database we decided to look at was the Pediatric Health Information System, which takes 48 large children's hospitals, and they all upload their clinical data into one database that you can access. This one has a little bit less, has about 5 million admissions, but it's updated. The kid database is updated every 3 years, so 2003, 2006, 2009. This one's updated every 4 months, which is great. You can also track patients across encounters, so you can look at readmissions and recurrence with it as well. But it's not nationally representative. It's just representative of tertiary care hospitals. So here's what we found. So looking at the KID database, we found about 1,900 cases of Stevens-Johnson. Stevens-Johnson, TEN, or the overlap syndrome. And so the largest study that adults found retrospectively was about 400 patients. So we were pretty shocked to get this many and this is the 2009 and 2012. So this is 2 years worth of data. And when we looked at it by age, we did find increasing correlation with age that was statistically significant. When we broke it down by specific diagnosis, and there might be a little bit of bias inherent here in if somebody was less than 10% or 12% body surface area, there might be a little bit of mixing between your diagnoses depending on who is doing your body surface area calculation, but in general, it goes along with the rest of our data of a mild, moderate, severe type of skin reaction. So we had about 1,500 cases of Stevens-Johnson, which you would expect that to be the most when you look at adult data, and then the overlap syndrome, and then TEN. When we looked at the national incidence, we found when we looked at the weighted numbers versus the weighted population, that the national incidence was 13.7 per 100,000. And so that's a lot more than the 0.5 per 100,000 that you see in adults, or that's been reported in adults. So this is probably more common than we make it out to be. And you could argue that maybe our diagnosis codes aren't specific enough and they're picking up some other things, but this is still well beyond what the numbers are in adults. And nobody's done this type of study with a large database in adults, so I imagine if we did it there, it would probably pick up more cases. What was interesting to me is this right-hand column looks at incidence per the actual population for that age. So where that box is, that's 6 to 10 years old, there's a population of about 650,000, and then looking at what is the incidence for that 650,000. And we found that when you're 0 to 5, your incidence is about 4, and then it skyrockets in the 6 to 10 range to about 61, and then 58, and then starts to go back down. And when you look at this temporally, that's increasing up until puberty, and then it starts to go down. And we know that all this immune stuff happens when you're ramping up for puberty, and something in that process is probably making kids this age get more Stevens-Johnson. So when we look at the tertiary care hospitals for the PHYS data set, that one looked at 10 years worth of data, well, 7 years worth of data from 2008 to 2015. And for that, we found 1,090 total cases, but for index cases or initial cases, there were 1,015. And then we had a recurrence rate of about 7% in that 7-year period. And then about 5% actually had more than one recurrence. And so these are cases by year from that PHYS data set, pretty steady. The 2008 is the year that the ICD-9 codes changed, and so we really only picked up part of 2008, and that's probably why the numbers were so low, but for the most part, they stayed pretty stable. One of the things that we're trying to do in pediatrics is look at kids who have complex chronic conditions, because we know that this accounts for about 10% or 12 million children in the United States, but they disproportionately use healthcare resources. They use about 40% of our hospital days and about 43% of our hospital resources, and they also have a much higher rate of death prior to age 18 than do kids who are previously healthy. So with this PHYS data set, they have a diagnosis-related group, or DRG, that is complex chronic conditions, which is any child who has one or more chronic conditions that leads them to see a physician more than like once every 4 months. And so with that, we decided, well, let's see what people are doing in healthy kids and see how they're treating these kids with complex chronic conditions. Insurance-wise, we're pretty nationally representative between commercial and Medicaid and self-pay. And then our geographic distributions, there was nothing too wacky here. We were, hoping maybe there was a big spike in one region, but when you look at this by population, it's about right. The incidence is about the same throughout. So management. This was pretty shocking to us. I was working with an infectious disease doctor at Mercy Children's to get this data, and she was very surprised at how much labs these kids get. Everybody altogether gets a lot of laboratory tests done. And Stevens-Johnson is a clinical diagnosis. So none of these are going to help you diagnose your patient, but they get all of them. Whether that's because they look sick and people get a little nervous, whether it's they're searching for an alternative diagnosis, we don't really know, but this is a lot of testing for somebody who comes into the hospital. But when you break it down by healthy children and those who have complex chronic conditions, for just about everything, the chronic condition kids get more testing. So regular old BNPs, they get more of, they get more blood gases, and they get more, MRIs. Those are just examples. We have, pretty much every test you can think of and scan, and these chronic kids are getting more of them. So they're using up more resources. The question is whether they needed those resources because they're sicker, or whether people just see that history of chronic conditions and are more conservative with those patients, which tends to happen. When we looked at treatments, so this is just tertiary care hospitals, all comers with Stevens-Johnson, what are the treatments people are doing? So again, this is not an infectious process to begin with. Later on in the course, they do get infections, but initially, over 75% get antibiotics. This appalled my infectious disease colleague at Mercy Children's. More people are getting steroids than are getting IVIG. So more than half are getting steroids, a little bit less than half IVIG. A lot of kids are getting antivirals, and we think this might be because sometimes this can look like herpes to begin with. Or maybe they think that there's some viral infectious process that's causing it and they're getting them, but about 20% of patients are getting antivirals. And then when we look at other immunosuppressive treatments, they're sort of decreasing incidence the more specific that you get. But when we break it down by chronic conditions in healthy children, kids who have complex chronic conditions get more antibiotics on admission, so more empiric antibiotics to start, and then they also get more antibiotics started after admission. So when they think they might have an infection, they also get more antibiotics. But the difference between antivirals, there wasn't a significant difference. When we look at immune treatments specifically, complex chronic kids have more steroids, more IVIG and steroids, and more other immune treatments, which is we just picked all of your specific antibody inhibitors and lumped them into one category outside of TNF inhibitors, and they got more of those as well. The only thing that they didn't get more of was cyclosporin. And when we look at the length of treatment, the healthy kids got less IVIG and less steroids. So it's the difference of a day, but those are expensive treatments, and so they probably add up. This was one of our indicators of disease severity. So when you look at what procedures did people get, so when you look at peripherally inserted central catheters or PICC lines where you do long-term antibiotics or IV treatments, the chronic kids got more of these by far. When you look at mechanical ventilation or intubation, there was a huge difference between healthy kids and chronic kids. When you look at central lines, when you look at plasmapheresis, kids with chronic conditions had more invasive procedures than previously healthy kids. So, outcomes. One of the more common and more serious complication of Stevens-Johnson is sloughing of the respiratory mucosa in the lower respiratory tract that leads to respiratory distress and failure and death. And so we decided to look at what are the respiratory complications between these groups. So people bill these a little bit differently. We looked at them separately. We thought about lumping them together, but this is essentially people who are in respiratory distress and need help with their breathing. And kids with chronic conditions had far more respiratory failure, distress, and insufficiency than previously healthy kids. So they were probably sicker than the healthy kids. When you look at other complications, these are there's a whole list of complications you can look at, and we have the data for. These were the serious complications that had a difference between the two groups. So the kids who have complex chronic conditions had more hypotension, sepsis, septic shock, small bowel ulcerations, acute kidney injury. So they got all of those. We think that they got all of those treatments and the longer treatments because they did have worse disease. Or at least they had worse complications of their underlying disease. As far as length of stay, when you take all comers and look by age at their length of stay, this is compared to the 0 to 5 age group. There really wasn't much statistical difference except in the 15 to 18 year group. Those kids did tend to stay a little bit less than the kids in the 0 to 5 group. 0 to 5 is a tricky age for clinicians. People tend to keep them in the hospital a little bit longer and be more conservative with younger children. And so we think that even though the 0 to 5 age group did well prognostically, they stayed in the hospital a little bit longer, probably because people were a little more conservative with them. When we look at length of stay by diagnosis, this was no surprise. The worse the disease, the longer they stayed in the hospital. The average length of stay for Stevens-Johnson was about a week. For TEN, it was about 18 days. However, there were patients who were in the hospital for several months with their TEN. And so when you look at the log of length of stay and a histogram, which I didn't add in here, but it does show statistical significance between these groups. So when we look at mortality in the Children's Hospital, this is really where the money in the study was. So overall mortality at tertiary children's hospitals is about 0.5%. So this is markedly lower than that in adults of 10 to 30%. There are some studies in adults that look at TEN and show a mortality of 70%. Those tend to be a little bit older. The newer ones say about 30%. But this is even lower than those smaller studies that we saw with 50 to 80 cases of kids that had a mortality rate of 2%. What was interesting about this, it was lower, but also no kids who were previously healthy died. They all lived and they were all discharged from the hospital. But those with chronic conditions had a higher mortality rate, about 3%. And so if you wanted to look at, well, what is a risk factor for death, having a complex chronic condition for Stevens-Johnson most likely is a risk factor for death. And we can probably counsel patients, if you are previously healthy and don't have any chronic conditions or any chronic medications, that you're probably going to do pretty well with your Stevens-Johnson or TEN. As far as living, you may have a lot of complications, but at least you're not going to die. One of the other indicators as far as mechanical ventilation, I showed you this in a graph earlier, but when you look at the numbers, it's pretty striking that the chronic kids got intubated a lot more than the healthy kids. So that was the phys data set at tertiary care hospitals. So we said, well, tertiary care hospitals get the worst cases of everything because they get referrals from community hospitals. They treat about 33% of children in the United States, but what about the rest? So we looked at national mortality. And we actually found it was lower than in the tertiary care hospitals. And my hypothesis is that all of the very bad cases went to the tertiary care children's hospitals, and they're a little bit skewed as far as the severity of disease. But no matter which data set you look at, outcomes are much better than they are in adults, and they're better than we previously thought they would be in kids. Another interesting point is when you look at mortality by age group, we saw that big spike in incidence between kids 6 to 15 years old. It went from like 4 to 61 per 100,000. Even though the incidence was higher, their mortality rate was the lowest in those groups. So even though they had more Stevens-Johnson, they all did pretty well with it. And then the mortality starts to go back up again when you're 15 to 18 years old, although it's still a very low mortality rate. And these were, the 6 to 15-year-old group was statistically significant. So when we look at your odds ratio, kind of think of it as your relative risk of death since the incidence is pretty low. Compared to Stevens-Johnson diagnosis code, those with the overlap billing code had a higher odds ratio for death, and those with TN were even higher, which you would expect. You know, the greater the severity of disease, the worse that your outcome is going to be. So costs. So when you break down costs, this is with the KID database, so the nationally representative database. When you look at, we're using hospital charges or billing as an estimate of our cost. Those who have more severe disease use more resources, which you would expect. So Stevens-Johnson will run you about $50,000, TEN about $200,000 per episode, per admission. When you look at by age, those in the 0 to 5 age group cost the most, which holding the theory that people are more conservative and keep them longer and do more treatments, that tends to make sense. That 6 to 15 group, where they tend to do better and have low mortality even though they have a higher incidence, the cost per admission is lowest, and then it starts to go back up again with your 15 to 18 age group. National costs, overall the burden of disease is about $150 million. Even though Stevens-Johnson costs less per episode, it has a higher incidence, so it actually costs about $85 million over the course of 2 years. And then TEN is less, but still significant given the number of cases that they have. So some conclusions from our study. Children get Stevens-Johnson more than adults do, and they get it a lot more than the studies that we have in adults. But they do better with it. They don't die as much. The mortality rate is less. Other indicators of length of stay, costs, are all better than in adults. We know that children with complex chronic diseases have a worse course of disease. They use more of our medical care resources for Stevens-Johnson, and they also have worse outcomes compared to kids who don't have complex chronic conditions. And no matter what disease you have, Stevens-Johnson, TEN, whether you're healthy or whether you're a complex chronic kid, this is a high-cost disease. So some things that we're looking at and other people are looking at, erythema multiforme major is probably a mild form of Stevens-Johnson. And the problem you get with it is it's not as specific for the disease. People don't bill often as accurately for it as they do with Stevens-Johnson and TEN. And so if you could include this into your studies, somehow having true erythema multiforme, it'll probably change some of these cost measures and incidence measures. One thing we couldn't do with this study that I would love to do with the TrueVin database is find out which drugs in kids are high risk. So there was that one study that looked at 80 patients and 200 controls, but that's not a lot. If we can look at a database with millions of kids to try and quantify which drugs cause Stevens-Johnson and what is your relative risk of getting Stevens-Johnson with those drugs, that would be very clinically significant for physicians. Identifying which kids are high risk to get Stevens-Johnson. So yeah, we know if you have lupus, you're at higher risk, but there are a lot of previously healthy kids who got Stevens-Johnson. And why did they get it and not the millions of other kids who had that same drug or got that same infection? Right now, we're running the numbers on readmission, both readmission, 30 days of any cause, and also recurrence rates to try and identify which kids are more likely to get readmitted and which kids are most likely to have recurrence of their Stevens-Johnson. That recurrence rate was 7% in children, so it's not nothing, but it is better than the 15 to 30% in adults. And we'd like to improve our are measures to risk stratify who is going to do well with this and who isn't. So we know complex chronic kids have worse outcomes, but between those previously healthy kids, is there any measure that we can identify that says they will do better or do worse? And then treatments, which of these immunosuppressants is the most efficacious? Should we be doing IVIG and steroids in 30% of these kids? Probably not. Either we should be doing it in all of them or not doing it in any of them. Maybe TNF inhibitors are actually the most efficacious. We have no studies comparing anything with Stevens-Johnson. So just some acknowledgments. Jennifer Goldman and Brian Lee helped me with the FIS data set out of Mercy Children's, and then Alan Schwartz did the statistics for the KID data set here at UIC. That's it.
Time for some questions. Anybody has some?
I do.
Yeah.
Thank you. Is it common in pediatric studies to do the categorizations of 0 to 5, 6 to 10, 11 to 15?
So it's all subjective in what your disease is. So we randomly chose those age periods. What you could argue is there's a zero. Neonates can get Stevens-Johnson. There are case reports of kids who are 6 months old, 30 days old who get Stevens-Johnson. So looking at 0 to 1 might be a separate group than the 2 to 5. We were just looking for broad groups that were pre-pubertal and post-pubertal and peri-pubertal to see in your immunological development with your hormone changes, are you going to see a difference in incidence? And we happen to catch it with those groups.
That's right. You said something about puberty could be associated in some way.
Yeah.
I don't know if you guys have yet run girls versus boys, but especially 6 to 10, then 11 to 15. A lot of girls are joining the sisterhood much earlier, age 8 or 9 or 10. That's why you might want to be a little more granular.
Yeah. We had a lot more kids in this database than we thought with Stevens-Johnson, which was great. Everything we did was statistically significant, but it makes doing your subsets a little bit more tedious. And so we are doing gender-based risk stratification, and then it would be nice to do just a regression of age to see it. I don't know if we're going to have the numbers to do that, but I completely agree. I bet if we looked over time, which we can't do in these data sets because they don't go back far enough, but looking at when women start their menses has decreased over the past 2 decades, and you might be able to see a trend of changing incidence with Stevens-Johnson or other immunological diseases around the same time, but these databases only go back to the late 90s, so we may not see it.
Have you looked at the impact of race or ethnicity?
So we're doing it now. So when we looked at comparing the healthy kids and the complex chronic kids at the tertiary care hospitals, we did run some statistics for ethnicity and didn't find any changes in race or ethnicity, looking at Asians, which was surprising because they're supposed to have a higher risk, and we did have a decent number of people from the Asian population. But we didn't see any difference between blacks, whites, Hispanics, or Asians.
Do you have the ability with the hospital database to look at when medications were given or discontinued?
Yeah, so we can't. We can only look at, and that's why we couldn't do the relative risk of drugs, is because we only get the drugs they got during the hospitalization, but not when they got them. With the FIS data set, there is, I believe, a way of doing it by day, but I'm told that it's not as accurate, and people kind of log them a little bit later, so you really can't do true analysis with it.
Okay.
Yeah.
Because one of my thoughts was around the kids with complex chronic conditions. Is the condition a modifier in whether they survive or not, or is it that the medications, the offending medications, are left on longer because they're chronic conditions and people don't want to stop them?
Yeah, it's a really good question. We don't know if it's because they've been on the drugs. They don't stop the agents because they need them, because sometimes these kids are on an antibiotic that there's nothing else that's going to treat that chronic infection, so you kind of have to keep it on. Or if it's because they're on 4 antiepileptics and they stop them sequentially so they don't go into status epilepticus, and it just so happens the last one they take off was the one that was causing the problem. But it'd be difficult with this database to tease that out.
Yes, on a similar note to that, for the antibiotic use, you said that was really see it being bad, but they were on it for something else, and can't look at the temporality. Could they also be prophylaxing because they know these kids are more at risk of infection?
We think most of them are prophylaxing, actually. So we could do a little bit of looking at, it's not well captured in the database, but we could look at a little bit what were they on the day of admission and the kind of the day after admission. And when we tried to kind of estimate were these kids on something before, very few of them were on antibiotics coming in that were that you would think they would be treating an infection long term for. The fact that when you look at pre-admission and post-admission, there were big differences there. We think it was probably prophylactic and they were taken off. Because they come in looking like they have an infection a little bit.
Along the same lines, I was going to ask, so were there any, I can't remember all the stuff that they did when they came in. Was culture part of that?
Yeah.
So was there any, could you look at, they did have culture positive and they did give them the right antibiotic? Could you see that?
The problem with these databases is you can't. So you can see that they got a CBC, but you can't see what the white count was. You can see that they got a blood culture, but you can't see the result. We did search for every bacteria that has a diagnosis code and then EMEA behind it. So, E. coli in your blood, Neisseria in your blood, all those things, and there were very few in them. So the ones that we did get tended to be the ones that were later, sort of the longer term complications. Yeah.
I have to say that not a question or comment, not about your work, but about some of the data that you already presented, looking at risk factors associated with medications, right? I'm very skeptical of a lot of those. They seem to be high risk for protopathic bias, where they're actually treating early stages of Stevens-Johnson rather than causing the disease. Tylenol, antihistamines, right? Corticosteroids, all those things, I don't know that they're really the causative agent, but rather they're treating early symptoms associated with the condition.
Yeah. There's not a lot that I truly feel comfortable saying about the causes of Stevens-Johnson in kids, just because the studies are so poor or have so few subjects in them. That I think the only way we're going to find it out is doing a big data set. That prospective studies aren't going to get enough, and retrospective studies at single centers are going to have this problem.
Just trying to clarify the consequence. Is there just lack of knowledge on my part from time of initiation of whatever the environmental factor is to occurrence of Stevens-Johnson? Is it a pretty quick time course, or is it?
So it's highly variable, and so some people think that there's this dwindle period where if you have your immune system starting to ramp up, you can have a couple of days before you see symptoms. Some people have pointed to if you give a lot of a large quantity of drug quickly, that you see symptoms almost immediately. And so it might have to do with how much immune complex load you're inducing with whatever your stimulus is. So an infection, I would imagine, would take longer than a drug to start the process.
I was thinking when you were talking about the 6 to 10-year-olds and the puberty thing, or sisterhood, which I haven't entered yet. That could it also be that they're exposed to more drugs that might cause?
Yeah. Yeah. I mean, I don't think there's any way that this isn't multifactorial. I mean, it has to be. And it's probably a number of different conditions with their immune system getting primed to over-respond to something and then getting more stimulus than you do when most 0 to 5-year-olds are healthy. They get an antibiotic for an ear infection every now and again, but they're fine. There are some with problems, but for the most part, they're healthy. And then you get into kids with trauma who are getting some medications at school, kids who are that's the age where you start to get in your mom's purse and take medication. That's where they've had now multiple medications in their life for different short-term problems. So I bet it's a multifactorial problem.
So I have a different kind of a question. You've published this? Is this out already?
No, we just finished the manuscript and are submitting it. Yeah.
What are your expectations of how these data are going to be received, like by American Academy of Pediatrics and kind of a larger? I guess my bigger question is wondering, do you feel like the message here is strong enough that it could fuel some type of a national interest in being able to develop better capture of these cases and do a bit more prospective research?
Stuff like this tends to be very well received without having much come out of it, because it's almost like an orphan disease, not technically, but it would cost, I think, more money than people are willing to spend, because in pediatrics there's a lot of other things that are you can probably help more kids by putting the money into. We tried to get the AAP actually approached me and said, can you do some off-label drug research? And I said, yeah, absolutely. How much funding do you have? And they said nothing. We just want to get some data for the AAP. So they have money that they're spending other places, but efficacy studies, off-label studies, drug studies, they don't want to spend money on.
Did the little girl survive the $63 million case?
She survived, but she had 150 surgeries. She has about 10% of her lung volume, and essentially lives in a hospital. She gets admitted, every few weeks. So she had a very, very poor outcome. And so when people read that and you try and prescribe them ibuprofen, if families have seen that case, they go nuts. It'd be great to say, well, that your risk of getting that from ibuprofen is 1 in 10 million, but we can't say that. We just know that it can happen, but we don't know how often. And so whenever there's a case like this in the news, it makes it a lot harder for us to prescribe medications, because we get a lot of pushback from families. And you can't say it's not going to happen. It's going to happen to somebody, but it's probably not going to happen to them.
Okay, well, thanks.
Yeah, thank you.